Welcome to everybody to our sixth annual Utah Elder Abuse Awareness Day. And I want to thank especially Tracy Lee and those at Adult Protective Services and the Department of Health and Human Services for all of their work in coordinating our partners and working to make this happen. It continues to be a success. We have well over 100 attendees today and expect this to continue to grow. So happy to have you join with us, and we're going to be thoroughly enriched today. I want to thank our partners, including the Area Agencies on Aging Network in Utah, U4A, Utah Commission on Aging, the Alzheimer's Association, Senior Blue Book, AARP, and of course, the Department of Health and Human Services, and specifically the Division of Aging and Adult Services, which is led by Mr. Nels Holmgren. And Nels, we're going to turn it over to you in just a moment to talk a little bit about the WISE program. And then when he wraps up, we'll introduce our other speakers. Our topic today is Seen and Safe, protecting older adults facing isolation, mistreatment, and neglect. And we have two national experts today who will be sharing their thoughts, their experience, case studies. And just as an aside, it turns out they're both first cousins. That wasn't planned, but it's just a nice little added cherry on the ice cream there. So glad to have both Kristen with us and Dr. Tim Farrell. Nels, I'm going to turn the time over to you. If you would talk a little bit about the WISE Initiative update. Thank you.
Absolutely. Appreciate the opportunity to discuss this important project that has been going on for a while now. For those of you not familiar with the WISE Initiative, this is one of the pillars of Governor Cox's second administration. He told us almost 2 years ago now in a group gathering with Utah's centenarians and their families that going into his second term, he wanted to make aging a major focus of that term, and was good to his word. In December of 2024, as part of the release of his annual budget, he initiated the WISE Initiative. WISE is an acronym, of course, as all good government program names are. It stands for Wealth, Independence, Security, and Engagement. This kicked off in early 2025 with some listening sessions that were held around the state. There were 8 in-person listening sessions and then some online options as well. Gathered a lot of thoughts and feedback and ideas from older Utahns, from caregivers, from policymakers, local leaders, nonprofits, government organizations, all kinds of people that presented lots of great ideas. And then late last summer, we put in place 4 work groups, each aligned with one of these elements of the WISE Initiative. They met through the fall into January of this year, and then all of the those work groups contained a lot of people from a lot of organizations. There are probably close to 80 different organizations represented in that. Government agencies, business leaders, again, nonprofits. We have legislators participate, county commissioners, lots of folks participating in that. And we gathered those, and their purpose was to come up with things that could serve as a menu of options for policymakers, ideas on how to implement the various elements that were included in those work groups and in those listening sessions. We gathered all of that together, and that has gone through a very extensive internal review. They came up with some final recommendations. Those were then shared with the steering committee, which are some very highly placed folks, including Rob Entz, who serves on that steering committee. It was also passed back all of the work group members for some clarification and refining and some updating to those recommendations. It is now in the final stages of being having the final formatting done so that this can be released for public comment. That will happen within the next week or so. This will be going out. It'll be blasted to all of the people that participated in the listening sessions, the work groups, other people who have expressed interest, and anyone who wants it. This public feedback period will be 2 or 3 weeks in which people can give their thoughts and show support or advocate for changes to these recommendations, and then those will be gathered back together. We anticipate that in mid-August that the final recommendations and the final plan will be released, and then we'll look forward to upcoming legislative sessions and other efforts on the part of the legislature, executive branch, other agencies that and partners that can then take these recommendations and start moving them forward. So we're kind of at the I don't know if it's the beginning of the end or the end of the beginning, because once this plan is finalized, then the real work begins. But we are close to having that draft public feedback version of the plan out there with the idea of finalizing it later this summer. And that is the WISE initiative and where we currently stand. Rob, I'll turn it back over to you.
Nels, thank you for that update. We all look forward for the opportunity to weigh in and respond on the work that's been done and for the ultimate publication and work going forward with the WISE initiative. Appreciate the governor's efforts with that as well. I want to introduce Dr. Kristen Lees Haggerty. She is the director of the National Collaboratory to Address Elder Mistreatment. Sounds like it's a great fit. Kristen, we'll turn it over to you.
Thank you so much, Rob. I'm getting an echo. It's okay now? Okay. Thank you so much. It's an absolute pleasure to be here. My name is Kristen Lees Haggerty. I'm a researcher and project director at Education Development Center, and as Rob mentioned, the director of the National Collaboratory to Address Elder Mistreatment, which is a John A. Hartford Foundation funded initiative bringing together experts in elder mistreatment from across the country. And also, as Rob mentioned, I'm here today with my first cousin, Tim Merrill, and we are going to present to you today on protecting older adults facing isolation, mistreatment, and neglect. And we thought it would be fun to start today with a case example. So Tracy, if you wouldn't mind going to present.
Let me ask everyone to make sure all of their microphones are turned off.
Thank you. Okay, that seems better right now. Okay, so hand it over to Tim, who's going to present a case, and you see on the screen Jason Momoa, so you'll see why in just a second.
Thank you, Kristen. Can everyone hear me? Okay, it's wonderful to be with all of you, and also with Kristen. As she mentions, a bit of a family affair, and we're really pleased to both be in aging careers, and our careers have sort of independently intersected and overlapped in a very nice way, and this is a great example, so we're really excited to be with you. So I'll present a case of a patient of mine at the University of Utah Madsen Geriatrics Clinic. You might be wondering why this case is starting out with a picture of Jason Momoa. I'll explain that in just a moment. But I just want to say I have permission from the family to talk about this, but everything's de-identified. So I care for a woman in her early 70s, again, at the University of Utah Madsen Geriatrics Clinic. I'll call her Jane. Jane graduated from high school and was widowed about 10 years ago. There's been a long-standing concern that she may be neurodiverse. She's also had hoarding behaviors and has had a psychotherapist over the years. So that's kind of the clinical context. She also lives in a subsidized housing community. In 2020, when her parents passed away, a trust fund of $150,000 was established according to her parents' will. A couple years later, this was all before I met Jane, a couple years later in 2022, She was nearly evicted twice due to hoarding behaviors, and she had more than 10 close calls of being evicted over the years. Her sister, Jane's sister, who I'll call Lori, has helped clean her apartment to prevent eviction. But due to nearly being evicted several times, Lori decided to dedicate funds from the trust to hire a housekeeper. Fast forward now a couple years later in 2024, an online scammer posing as Jason Momoa convinces Jane to provide upwards of $10,000 in payday loans as part of a romance scam. And when I met with Jane, she told me several times, completely convinced that Jason Momoa wanted to marry her. And she was planning to drive to Las Vegas to meet him at a chapel. And that was discussed over several office visits with me. The payday loan expense ended up having to be paid through the trust. And her sister Lori noted that the payday loan was almost as much as Jane's annual income of about $15,000. So, with a lot of discussion, Jane eventually sort of swore off the romance, but Lori discovered that Jane had actually still continued this relationship with Jason Momoa slash the online scammer when she saw a Facebook notification from the scammer posing as Jason Momoa. And when confronted by Lori, Jane actually unfriended her family on Facebook. Lori then, after all of this, decided to initiate a conservatorship because, in Lori's words, the trust had been supporting Jane's bad financial decisions. Now, in 2025, and this is kind of bringing everyone up to date on what's happening most recently, my patient was photographing codes from Apple gift cards and IMing the codes to the scammer. She also appeared to be using her monthly Social Security income to pay for the Apple gift cards. So Lori sent certified paperwork to lock Jane's credit with all three credit bureaus and made an appointment with the Social Security office so that Lori would appear as a payee and Jane's monthly stipend would be protected. Lori also opened a new checking account from the trust to serve as Jane's new account for Social Security receipts and dispersals. Even then, as of February 2025, Lori could not see any evidence that Jane received her February Social Security deposit, again raising concern for fraud or some kind of other diversion. So, over the last 5 years, over the course of what I've just described, Jane's emergency money or trust fund, an account set up by her parents and entrusted to Lori, has gone from $150,000 to less than $95,000. And in my most communication with Lori, she was concerned that her sister Jane may outlive her resources. So, I think in the context of what you'll hear from Dr. Lise Haggerty and the WISE initiative, I think this case is what we're seeing a lot of on the ground with these romance scams, sadly. And I'd like to now turn over the virtual podium back to Dr. Lise Haggerty.
Thank you, Tim. It's an upsetting but very helpful example, I think, to have that real life case story. So now I'm gonna zoom us out a little bit and provide some background on elder mistreatment. I know we have a lot of folks on the line. I'm like, oh my gosh, 128. And so there might be varying levels of familiarity with elder mistreatment. Yesterday was officially World Elder Abuse Awareness Day. So I'm gonna give a little bit of background and then we'll switch the focus over to specifically thinking about social isolation and rural older adults. So here's my agenda for the day. Background, talking about some barriers and facilitators to addressing elder mistreatment, and then social isolation, abuse, neglect, and self-neglect, with a little bit of time perhaps for Q&A, although we might hold that until after Tim presents his stuff. So if you could go to the next slide, please, Tracy. And next slide. One back.
Are we seeing the slides?
Yep, I think, well, I can.
That's great.
Okay, great. So again, I'm here kind of in my role as a director of the National Collaboratory, and I just wanted to share with people that this initiative has a pretty lofty goal of trying to integrate the issue of elder mistreatment and elder justice into mainstream health and aging initiatives. So this is kind of a perfect forum to get the message out that we are doing this work by working to improve clinical practice, by providing tools and resources for clinical settings, specifically emergency departments, to help them better screen for, identify, and respond to elder mistreatment. We also have a mentorship program, so we're trying to build talent in how people do research, practice, and policy around addressing elder mistreatment. And we provide some thought leadership by bringing together experts in the field and aligned fields to think about how can we improve research funding and policy related to elder mistreatment. So I just wanted to give you that very brief background on the National Collaboratory to address elder mistreatment. And I'll pop the website into the chat in a little bit after my presentation, but I just wanted people to kind of have a little framing of who I am and what the initiative is. And next slide. Just to set the stage, definitions of elder abuse, neglect, and self-neglect are included here. And so I'm sure many folks on the line know this, but elder abuse is defined by the National Center on Elder Abuse as intentional actions causing harm or creating a serious risk of harm to an older adult. And that person is typically in a trust relationship. So there's an expectation of some sort of caregiving. Neglect is the failure then of a caregiver to fulfill their obligations, resulting in some sort of harm or distress. And then self-neglect is a situation in which an older adult is unable or unwilling to provide their own basic needs. And that can include hygiene, nutrition, hydration, medical care, and safety. Typically it's to the extent that it threatens their own health or well-being. And that's according to the American Geriatric Society from 2021. So just to kind of get some definitions out there. And on the next slide, I'll share a little bit of prevalence data. And we do know, a lot of you all are working in the aging field, and even in the aging field, we find a lot of people are surprised to learn just how prevalent elder mistreatment is. And so we have some national data suggesting that elder mistreatment is affecting at least 1 in 10 older adults in the US, and that's among community residing and cognitively intact older adults. We know that these rates are much higher in people living with cognitive impairment and people living in nursing homes. But even among the community residing older adults, we also know that elder mistreatment is pretty woefully underreported, underrecognized, and underreported. And there are data that suggest that only 1 in 24 cases of elder mistreatment are reported to authorities, such as Adult Protective Services or law enforcement. And with the growth of the aging population in the United States, we expect these numbers to grow. And so if these rates stay the same with the growing population, there will be 7.3 million older adults in the US who will be mistreated in 2030, and more than 7 million of those cases will go unreported. So it's a prevalent issue. We know it has devastating consequences. And if you go to the next slide, please. And this slide really illustrates how context matters, in that the kind of rates of elder mistreatment differ for different groups. For example, rates are higher in long-term care settings. There was a 2019 publication finding that 64% of nursing home staff admitted that they themselves had done some form of elder abuse in the past year. And then the rates of elder mistreatment among people living with dementia, those are reported at up to 50% in the United States. And so these can be kind of shocking numbers for people to see. On the next slide, broke it down a little bit by type. So these again are national data that are specific to community residing and cognitively intact older adults. And you see that the most prevalent form of elder mistreatment that we see is financial exploitation, followed by neglect, emotional abuse, physical abuse, and sexual abuse. This specific study did not look at self-neglect. The rates of self-neglect are typically towards the top of that list if you were to add those in. And then we may ask ourselves, okay, so it's pretty prevalent, but what happens? Why do we care so much about this issue? So if you go on the next slide, you can see kind of, one, we know that there are devastating health and social consequences for people who experience elder mistreatment. And it affects both the people that experience it and their families and their communities. Some of the things that you see on this slide may seem obvious, while some others may be less obvious. For example, I think it makes sense that someone who's abused would experience emotional pain. They'd feel helpless and fearful, experience increased stress and depression. But it may be a little more surprising to learn that elder mistreatment is independently associated with a 300% increase in death. And that's after controlling for chronic conditions and other predictors. We also see increased dependence, loss of physical and cognitive abilities, and then social isolation, which is a really important topic right now, and rightfully so, because it's both a risk factor and a consequence of elder mistreatment. And being secluded from family and friends is both something that makes people kind of more vulnerable and an outcome. And it's a well-known tactic by abusers to kind of socially isolate so that they can continue to perpetuate that mistreatment. And we can go to the next slide here. And just to mention that in addition to those sort of health and social repercussions of elder mistreatment that I just shared, there are huge, huge financial costs that are associated with the issue. For starters, it's been estimated that elder mistreatment can result in 5.3 billion, and I always say that's billion with a B, in healthcare expenditures every year. And that is related to the increased use of the emergency medical services, visits to the emergency department, more and longer hospital stays, and higher rates of nursing home admissions. And then there are, of course, the direct financial losses to victims, kind of as explained by Tim in the case example. Losses to victims of financial exploitation are in the tens of billions of dollars. And it's important to note that most of these are not random phone call and mail scams. Most of these, over 70%, are committed by somebody that the victim knows. So that's another kind of important piece of information when we're understanding the background about elder mistreatment. On the next slide, thinking about kind of social determinants of health and elder mistreatment. So it's critical, I think, when we're talking about elder mistreatment to think about it in the broader context in which older adults and those who are mistreating them are living. And social determinants of health are part of kind of the epidemiological story of elder mistreatment. For example, older adults who are socially isolated, they are at higher risk of abuse. Isolation can prevent them from seeking help and can prevent them from otherwise being identified as needing help. In a little bit, we're going to go into much more detail about the issue of social isolation. Then you have the topic of dysfunctional family relationships or history of family violence, history of mental and physical health problems, and lack of access to safe and adequate living environments that can increase the risk of elder abuse. Then healthcare, limited access to healthcare services. This can prevent people from being identified. It can also prevent treatment of elder mistreatment. And in our work, we've just seen time and time again, older adults who have been through the healthcare settings over and over again while they're being mistreated, and it's not identified. So we really do need some more focused efforts to get people identified earlier. And then finally, and I think in my opinion, most importantly, are cultural and social norms. And I don't think it would be a surprise to anybody to say, we have an ageism problem in the United States and globally. Ageism and other types of discrimination increase risk for elder abuse. And I would say arguably that elder abuse is the most egregious form of ageism. And to address elder abuse, we need to also be addressing ageism in this country. I think before I move on, one other thing is I feel that too often we focus on sort of the negative aspects of aging rather than the positive. And yes, it's challenging and burdensome and stressful to care for a loved one who's aging and is highly dependent. But older adults are important members of our families, our communities. They bring wisdom, joy, laughter. They carry our history, provide for families and friends as well as strangers. So I think to address elder mistreatment, we need to be returning consistently to addressing ageism. So I hope this resonates with all of you. And I'm going to kind of shift gears a little bit now to talk about some of the other barriers and facilitators to addressing elder mistreatment. And you can go straight through. Great. So this slide shows some barriers and facilitators to addressing elder mistreatment. Probably not a whole lot that's terribly surprising here. A lot of this work that that show a lot of the topics that you see here is based on a work we've done specifically with healthcare professionals who are, of course, a key partner in identifying and responding to elder mistreatment, but relevant for other groups as well. So we hear consistently that there's a lack of training about identifying and responding to elder mistreatment. Folks typically get a lot of training around addressing child maltreatment or intimate partner violence, but less so on elder mistreatment. There's also a lack of protocols and resources to respond to elder mistreatment. So oftentimes we hear that it's sort of, we identify elder mistreatment, but the response is pretty ad hoc, time consuming, and that many people have sort of a discomfort with talking about the topic of elder mistreatment. There can be stigma around sharing, the kind of what might feel as a private issue of mistreatment happening in a family. And then, of course, there's distrust in some of the systems that are in place to investigate and respond. We hear that, I don't want to call Adult Protective Services or law enforcement and get them involved. I'm not sure if this is elder mistreatment, and I don't want to kind of involve a system if I don't have to. And then when we think about what are some of the facilitators to addressing elder mistreatment, it's where there's opportunity to observe older adults, caregivers, and their interactions. Healthcare settings come up again here a lot because older adults are coming in often with a caregiver, opportunity to observe. First responders are another great example. One of the few kind of folks that might have access to the older adult's home and be able to observe environmental factors. We also hear that when there's a longitudinal relationship with older adults, it can really help with identifying elder mistreatment because you can observe change over time and recognize some of the shifts earlier. Willingness to have an open conversation, and this can relate back to training and making sure that folks that are interacting with older adults are able to feel comfortable having those more difficult conversations and asking questions. And then expertise and connections to identify and respond. And we're going to talk in a little bit more about some key community partners and ways to collaborate to address elder mistreatment. On the next slide, when I give these presentations, I typically talk about the role of Adult Protective Services from sort of a national perspective and recognize that there's variation across states. With this specific group in Utah, we'll get into a little bit more of the Utah data in just a second. But one of the things that we've found in working with healthcare providers has been there's a lot of misconceptions about what APS can and cannot do, and that can feed some of the hesitancy to report. So we always try to talk about, what APS can and can't do. So APS can do face-to-face investigations. They can help develop case plans and refer for medical assessments. They can provide, in some cases, they can provide temporary medications, home cleaning and repair, transportation, and connect older adult clients with emergency housing or placement in long-term care. And then some of the misperceptions that people have are, oh, I don't want to call APS and have this person ripped from their home or, dragged away from their family. And APS cannot do that. They cannot force older adults to accept services. They can't remove them from the living situation without a court order. And very importantly, in most cases, APS can't provide private information back to reporters against state laws. And this can be really frustrating. I think sometimes as a reporter, you make a report and you care about what's going to happen next, but you're not allowed to have that information. So we try to share, it's not always possible for APS to share back information and that it's still important to continue reporting and making every effort to connect the older adult to services through APS. All right, so next slide. So this one does focus on Utah's aging population and the growing need for protection and support. So my understanding is that Utah is actually currently one of the youngest states in the country, but that the older adult population is growing very quickly. And as that population ages, we know that demand for services will certainly increase. So focusing then on Adult Protective Services and Utah's Adult Protective Services, they can investigate abuse, neglect, self-neglect, and exploitation of vulnerable adults. And in Utah, I'm sure most people on the line know, reporting is mandatory across the board. This is a little bit different from other states where there might be specific groups that are mandated to report, but everybody is mandated to report in Utah. If you go to the next slide, In 2025, there were over 12,000 reports of alleged abuse, neglect, and exploitation in Utah, and that's an increase of over 40% over the past 5 years. The needs assessment data shows that, I guess, kind of unsurprisingly, the vast majority of older adults really want to stay in their home as they age. And interestingly, a significant portion, 41%, would benefit from services to prevent social isolation. And then a key takeaway from these data and the needs assessment is that social isolation, especially in rural communities, is a major safety concern. Social isolation is, again, one of the leading risk factors for elder mistreatment and is linked to mental health, cognitive, and physical health risks. So a really, really important topic to get into is social isolation. And then on the next slide, kind of in preparation for this presentation, I asked for a bit more information about the top investigations and the top confirmed allegations to APS in Utah. And it's interesting to see on this slide, you can see that the patterns align pretty well with the prevalence data, the national prevalence data I showed you earlier. So most common allegation in Utah was financial exploitation, followed by neglect, emotional abuse, and then in the prevalence data I showed you earlier, I didn't include the self-neglect because that data focused on abuse by other, but then you see self-neglect coming next, and finally physical injury or harm. Then in the confirmed allegations, financial exploitation and neglect, caregiver neglect, first two, with physical harm coming up as the third most commonly confirmed allegation. Let's move on to the next slide, and we're going to focus now on this topic of social isolation in relation to elder mistreatment. Again, social isolation is a really important leading risk factor for elder mistreatment, and let's look at why it's a kind of particular concern in a state like Utah, where there's a large and growing population of rural older adults. So we know that in rural areas, the low social support, well, across the board, low social support is the most consistent risk factor for several types of emergency department. Rural older adults are at a particular risk because in rural areas, we see that between geographic distance and service scarcity, there's less opportunity for support, and there's just less opportunity for surveillance because there's fewer of those sort of informal watchdogs that can be neighbors, friends, and family, excuse me, who might detect abuse. Additionally, with fewer available services, we might see less support for caregivers that can increase caregiver stress, caregiver burden, and risk for abuse and neglect. Fewer neighborly relations and limited networks, this can predict higher self-neglect in rural communities as well. And we also know that isolation reduces help seeking. Isolated older adults are less likely to disclose, they're less likely to seek services. Next slide. And then summarized another way, and in a bit more kind of detail, we can think about the unique challenges in addressing isolation in rural settings as falling into these three buckets. These are related to workforce and service scarcity, social and cultural, excuse me, social and cultural barriers, and geographic and infrastructure. And then as you see, I'm not going to read each of these to you, but you can see from these slides some interesting examples of these issues. And just thinking about geographic and infrastructure, logistically, if you have a long distance to travel and not much in terms of public transportation, it's hard to stay connected. I might not want to go to my senior center and engage in services if it means asking someone for a ride or to sit in a car for an hour in a snowstorm, these sorts of issues. Workforce, that's an issue everywhere, but hits rural areas particularly hard in that it's harder to recruit people and there are few people to be recruited. Rural programs are often underfunded, and we see this a lot actually in my home state of Massachusetts, where I live. There's this sentiment that, you know, Boston gets most of the services and the western part of the state, the more rural part of the state, gets fewer. So it can be hard to kind of advocate for services in some cases. And then finally, the social and cultural barriers. We've seen this in some of our work implementing elder mistreatment screening tools in emergency departments, that the folks who live rurally have more of a do-it-yourself attitude, which comes with a hesitancy to disclose abuse, a hesitancy to engage with services when they are offered, and a deep sense of privacy. And this is tied to, again, the larger issue of the perception that elder mistreatment is a private issue, not to be discussed. But we know from research conducted by the Frameworks Institute that public messaging about mistreatment should convey that it's a systems issue. It's not a private one that should be addressed in isolation. Next slide. So what can we do about this? Because that was a lot of it's really hard to address elder mistreatment in rural settings and hard to address isolation, but there are some promising practices. And, while they are too often underfunded, community-based programs appear to be our kind of best bet in addressing social isolation. And it's not just the existence of community-based programs, but how can we get community-based programs to work together in a more collaborative and connected way? In fact, there is actually increasing data supporting that community networks and collaboration can have really measurable effects on identification and response to elder mistreatment. They do this by helping to identify people that are at risk. They help with disclosure by reducing some of the stigma around talking about elder mistreatment, and by connecting people with services that can then follow up and check on safety. Also, when you're coming together in a more collaborative nature, you can improve efficiency in aligning resources rather than disrupting. And actually, I included this impact example on the side, the Rural Aging Access Network, or RAN. And it's a program that I learned about as I was preparing for this. It's a program by the Lutheran Services of America. It's a collaborative that helps underserved older adults in rural Minnesota, Montana, North Dakota, and South Dakota. And they help them age in place by connecting them with community-based partners. They mobilize local partners to identify what are the care gaps, and then they help coordinate services across healthcare, food, transportation, housing, and social connection. And they did a nice evaluation that's been published in peer-reviewed journals, and they have found that through their collaborative efforts, they've had a 450% increase in interagency referrals. 55% of the rural adults contacted by RAN were referred to needed services, so they have a pretty good rate of getting people to accept their services. Clients are consenting for data sharing across partner agencies. And then in total, they had reached 483 older adults in just one program cycle. Just wanted to share that as one kind of approach to interagency collaboration that has shown some promising data. On the next slide, and again, kind of with that example of the RAN model in mind, just wanted to provide some common community-based resources that can be helpful in preventing and addressing social isolation and thereby elder abuse. I'm sure many of you are familiar with these types of services, but it's been interesting in our work preparing healthcare organizations and community-based organizations for elder mistreatment response. Even folks who are working in the field aren't always super aware of how these different types of community-based organizations can play a role specifically in an elder mistreatment identification and response. So with that as sort of the kind of who, we're talking about APS, we're talking about area agencies on aging, Meals on Wheels, senior centers, community health workers, and multi-sector coalitions as kind of the who can be doing this work. Let's look on the next slide at the how, and what are some of the strategies for connecting resources with each other. Not only connecting resources with each other, but also connecting resources with the people who are isolated. And some of the take-home messages from, this is a busy slide, but I think we'll be sharing the slides after, so I thought it'd be nice for people to have kind of a reference there. But some of the take-home messages here are we really need to be proactive about identifying people who are isolated and who are being mistreated or at a high risk of mistreatment. And you can do this by incorporating standardized screening protocols and making use of different roles. For example, community health workers who can help identify people at risk. Another kind of take-home message is we need to make it easy for people to find services and easy for people to access services. And this can mean using a warm handoff protocol rather than a cold handoff. And that is, rather than handing a card with 10 different resources, are you able to help the older adult call the service that's most relevant for them, and doing more of a kind of personal handoff, and connecting them directly with the organization that can help them. Technology is increasingly being used to connect people, including through telehealth options. And this is a kind of nice area for more research around how can we screen for social isolation and elder mistreatment through telehealth. Volunteers and transportation programs are another good way. And this one's really important in rural areas because transportation can be the greatest barrier to access for some older adults. Another is engaging with trusted community members who may not be the first thought when you're thinking about screening for and responding to elder mistreatment. So in that case, we're talking about barbers, hairdressers, bank tellers, the faith community. And then finally, first responders, again, they are really well positioned because they have and in some cases, maybe the only people, outside people who have eyes on the home environment. And so training, for example, for EMTs to look for observational red flags for risk. This can be huge. Information gained by the home that then can be relayed to other providers at the emergency department and hospital, for example. Next slide. This one again is mostly for reference for later, but I just wanted to provide a few more examples of some evidence-based programs that are very potentially adaptable and adoptable. And these three programs that you see, one of which you've already seen the RAN, but then the RISE program and the Coordinated Community Response Program. The common thread between these is that they all combine screening, care navigation, they leverage existing workforce members, they leverage technology and data sharing to improve outcomes. So these are nice examples. And, you know, in the elder mistreatment field, we're actually at a really exciting time because for the first time we have real data on some interventions that work. So I just wanted people to kind of have heard those names and be able to follow up if they're interested. And then next slide. So for this group, I wanted to just kind of end with a couple of slides about what we can all do. So for practitioners and care teams, again, routine screening for social isolation, not just abuse, trying to get further upstream and get some prevention, asking about social connections, transportation and technology access, making those warm handoffs, training all team members to recognize signs of self-neglect and elder mistreatment, and documenting isolation as a clinical and social risk factor. For organizations and coalitions, building or joining those multi-sector collaborations and making sure to have shared referral protocols so that we can be more efficient about the way that we're using the community resources that are available. Invest in peer navigation or community health worker programs for rural health outreach, having as much as possible a single point of entry, making it easy for people to access services, sharing data and tracking outcomes across agencies, and again, prioritizing transportation and tech access as core services to improving rural access. And then my next, and I believe last slide, I wanted to leave you with this advice from an elder mistreatment expert and geriatrician and mentor of mine. Her name's Laura Mosqueda, and she's at the University of Southern California. And it's kind of like whether or not you and your organization are ready to implement a standardized, validated screening and response protocol, there are kind of littler things that you can do that are easy to do when you're working with older adults that can have a big impact on patient or client experiences. And so Laura, who is a geriatrician, she told us that she used to sort of say, when an older adult patient would come to her and say, for example, my grandson's moving in to help me care for myself, she used to say, great, I imagine you must be relieved to have some help at home. Now, after studying elder mistreatment for so long, she says, how do you feel about that? So opening the door for a conversation about maybe it's not the best move for the family, maybe there's some risk there, and giving the patient or client opportunity to talk about the pros and cons of having their son move in, as an example. And then the next slide, I think, is just some more resources, hopefully helpful resources around elder mistreatment. And that, I believe, wraps up my portion of the talk, and I will hand it over to Tim. And
so Kristen, I'm going to introduce Tim just a little bit more, if I may.
Sure.
And thank you very much. The information is incredible. And I think you mentioned that your willingness to share your deck with the group after. So we will follow up with that, and we'll probably put a little more detail on the background of these two speakers in the follow-up communication. I wanted to point out, as we get towards the end of this, as you leave the meeting, you should get a survey, a brief survey to fill out that just talks to us a little bit about how you connect with this conference. And we do intend to send that out to the group that registered as well, so we get a good feel that we're marketing this appropriately in the future. And Tracy will be managing some of the Q&A at the end. So I think we'll save questions to that point, if that's okay with everybody. And I don't know if Jean Boyak's on this call, but I think you made some great comments, Kristen, about resource, particularly rural, which is very, very timely for the work that we're doing in the state now. And also, Jean heads up some programs within the Division of Department of Health and Human Services, and a new screening tool for individuals to assess their ability, or rather to assess their concern about being vulnerable to fraud. And we may want to just insert that, Tracy, at the end, and if there's some time. Dr. Tim, thank you again, Kristen. That was incredible. Dr. Farrell is the Presidential Endowed Chair at the Division of Geriatrics, Professor of Medicine and Geriatrics Division Associate Chief for Age-Friendly Care at the School of Medicine at the University of Utah. He's also Adjunct Professor of Family Medicine and a Physician Investigator at the VA in the GREC program. His academic interests include age-friendly health systems, and also he continues to advance age-friendly initiatives locally, including service on the Utah Commission on Aging, regionally and nationally, and including efforts to oppose ageism. In 2026, Dr. Farrell was elected to the American Geriatric Society Board of Directors. So there will be more on Tim and Kristen in our follow-up. Tim, turn it over to you. Thank you for joining us.
Hey, thanks, Rob. Can you hear me all right?
Yes.
Okay. Okay, great. Well, again, it's great to be here, and also it's great to have Kristen's presentation, I think, which really aligns well with what I'll be presenting, particularly from the standpoint of being proactive in terms of our approach to patients who are highly vulnerable. I have no relevant conflicts of interest to disclose. So my objectives are fourfold. We'll talk a little about the age-friendly 4Ms first before diving into unrepresented older adults, because really this is sort of the framework perspective through which I think it's very helpful to think about this population, about some terminology, including unrepresented and older adults without potential surrogate and related clinical concerns. And I'll just also just convey my bias, as a geriatrician, I am seeing this clinically, and so my perspective may be a little bit different than elsewhere in the community, but I'll try to link back to some of the things that Kristen mentioned. Also want to talk about the Utah Uniform Healthcare Decisions Act that just became law in January. I think that has implications for everyone, but also for unrepresented older adults. And then I'll conclude by summarizing the updated American Geriatric Society guidance on caring for unrepresented older adults. Okay, so let's just start off with age-friendly health systems as sort of context. The idea is to build a movement so all care for older adults is age-friendly. And it's guided by this essential set of evidence-based practices called the 4Ms. I imagine many in this call may have seen the 4Ms embedded in the draft Utah Master Plan on Aging. I think they are well aligned with the WISE initiative. It's very much informed by patient safety principles to cause no harm and to be consistent with what matters to the older adult and their family, and that what matters piece will become extremely important for the unrepresented population, as I'll show in a little bit. So why do we really even care about age-friendly approaches? It's because this type of care is not reliably applied. So if you look at sort of older adults across the board, about 91% are not really receiving these age-friendly models. So we have great evidence base, but it's just not getting to those who need it most. And I would say that rural communities would be examples of this, but even in urban areas, one hospital may have a handful of age-friendly programs, and another hospital may have zero or few. And that's quite common, and we're trying to improve this. So a group of experts in geriatrics got together and reviewed evidence-based care models, about 17 of those models. I won't go over all those models, but for those of you who are familiar with things like delirium prevention, that was one of the models, as well as the GUIDE model that has to do with care for older adults and their caregivers when there's dementia. Those types of care models were reviewed and basically boiled down to 4 items that were in common. And here they are. So these are the age-friendly 4Ms, and it's sort of arranged like a compass rose with what matters to older adults as the North Star. And that's aligning goals of care with the healthcare that's actually provided. That may seem obvious, but in sort of usual practice, that often doesn't happen. I can say in medical, the chief complaint, what's the matter with you? But what matters most to you is not always asked. And so I still have to remind myself sometimes to include this in my practice. And this is just not happening universally, although it is improving. Um, Medication side effects that can cause issues, delirium and other problems that can interfere with the other M's, mentation, depression, dementia, delirium, and last but not least, mobility to be able to do what matters most. And I think a very important takeaway on this slide is that these M's are not in isolation. They all interact with each other. And so I like to tell the trainees I work with, if you can consider the four M's when you're caring for older adults, you will be providing evidence-based care. So just briefly, just for awareness, the Forums framework has been advanced by groups like the John A. Hartford Foundation, that Dr. Lise Haggerty mentioned, as well as the Institute for Healthcare Improvement. And to date, this number is actually a little higher now. It's closer to 6,000 individual practices. And also convenient care clinics like CVS Minute Clinics are now age-friendly. And this is also going into a next level designation called Community Care Excellence as well. So if you're in a health system context, you can join an age-friendly action community and apply to be have one of these levels of recognition. We were part of such a community. There were 30 health systems around the country who are doing an age-friendly system-wide spread collaborative. You'll notice there were several VA health systems, the VA being the sort of largest health system of its kind in the US. That single payer model. You'll also see CVS Minute Clinics and academic health centers involved. We are trying to exemplify how to feature these age-friendly evidence-based care models. I won't go over these, but just to give you a sample of what's being done at University of Utah, and maybe most pertinent for this discussion would be the patient priorities care, focusing on what matters, a very structured approach to eliciting that, and also the guide model. Again, an evidence-based approach to support older adults with dementia and their care partners. So I want to talk a little bit, just a couple slides about the CMS Age-Friendly Hospital Measure. And the reason I'm doing this will link back to unrepresented older adults, and I'll try to make that connection. So this is really important that Medicare now embeds age-friendly care into requirements that all hospitals have to do. This came out in August of 2024 and recognized that there are just increasing numbers of older adults with multiple chronic conditions. So drawing on the work of the AGS and IHI, the age-friendly measure seeks to ensure hospitals are reliably, sorry for the spelling error, reliably implementing the 4Ms and thus providing evidence-based elements of high-quality care for all older adults. This is very, very small font, but I'm showing that intentionally because this came from the Federal Register. So if you're ever looking for some bedtime reading to fall asleep, that's a good place to start because it's in micro, like 8-point font. But the key part is on the left-hand side. You'll see 5 domains eliciting patient healthcare goals, medication management, frailty screening intervention, social vulnerability, and age-friendly care leadership. Again, that all hospitals have to do. And thinking back to Dr. Lise Haggerty's slides, you'll be able to see ways that hospitals can be proactive in identifying patients at risk for things like elder abuse. And you'll notice, if you look on the right-hand side in the middle, under column 4A, they do mention identifying elder abuse. So this is actually now codified into Medicare regulations, and I'll come back to this a little bit later. And just to say, with age-friendly care in Utah, we are trying to build an age-friendly ecosystem, again, aligning with things like the Master Plan on Aging, which you see here. I think the big point here is that, I sort of work every day in a health system, but that's just one part of the age-friendly ecosystem. And so many of the things that Dr. Lise Haggerty was talking about really have to do with the entire pinwheel here that includes home and community-based services, public health, communities, cities, counties, et cetera. There is an age-friendly designation for age-friendly university, University of Utah. There's an age-friendly communities designation through AARP. So there's lots happening, and there are even some age-friendly states throughout the country. So I think this can really nicely align with a lot of the initiatives that Dr. Lise Haggerty was talking about with respect to elder mistreatment. So let's talk about unrepresented older adults and with the age-friendly health systems framework in mind. So this can get pretty complicated. If you look at the literature on the unrepresented, there's been a lot of terminology kind of thrown about. And so this slide is an attempt to kind of simplify that. So you can see at the top row here, older adults without potential surrogates, also known as older adults without advocates. I see these folks all the time in clinic. So a great example of this would be an older adult who was recently widowed, their spouse passed away, and their family live out of state or they're not involved with their family. That patient retains medical decision-making capacity. They have a completed advance directive, but they do not have a complete advance directive in most cases, excuse me, and they don't have family or surrogates willing and able to assist with most decisions. I'd say that's the majority of patients that do not have an advance directive. Then you go down to the bottom row, unrepresented. This patient basically is the same, except for some reason they've lost their medical decision-making capacity. And that's a problem because they don't have the advance directive and they don't have anyone immediately available to help with critical medical decisions. Unrepresented older adults have been called initially unbefriended. That was really a term from the legal literature, but that terminology is changing, as I will explain shortly. So I want to pose the question, what happens when it's difficult or impossible to find out what matters to an older adult? So the Forums framework really builds in the what matters as a central component. But in this population who lacks medical decisional capacity, they really present a challenge in terms of finding out what matters, because then it's difficult or impossible to align the care with what their goals are if we don't know their goals. So what ends up happening is you have what I'm going to call a continuum of vulnerability, where you start out with a patient who, like I mentioned, that patient who's maybe recently widowed, they lack an advance directive, and there's not really family available. Then there's a crisis. They show up in the ER, maybe they're in the ICU for some reason, and they lose, at least temporarily, their medical decision-making capacity. Now, by definition, they are unrepresented because there's no one for the care team to go to, and there's no documentation about their wishes. And then we're kind of in this murky area where what matters most is unknown, and we're kind of in the land of the best interest standard of doing what we think is best without knowing their preferences and maybe needing a guardian. So in terms of demographics, and I think this underscores what Dr. Lise Haggerty pointed out, the number of older adults lacking accessible default surrogates is only increasing. So you can see in 2018, about 15 million of the 92 million older adults, or about 16.5%, age 55 plus, did not have children. In 2020, about 27% of community dwelling older adults lived alone, and 42% of women over age 75 lived alone. And then 25% of community dwelling older adults are socially isolated, and 40% of adults age 60 plus report feeling lonely. Note that social isolation and loneliness are slightly different but related concepts, but overall, just to give the picture, there's just more older adults who are isolated and fewer people around to sort of act on their behalf. What about healthcare settings? What's the prevalence of older adults without potential surrogates? We don't really know, but we do know that, again, this number is just going to go up because the baby boomers are a group that's at high risk of becoming unrepresented, given that so many live alone and lack children. I just put Robert Putnam's book about bowling alone to emphasize some societal trends that are leading towards this more isolated way of living for many people. For the unrepresented, those who lack decisional capacity, lack an advance directive, and lack family or friends available to help, We know they often show up in the ICU. We think they're in long-term care. That 4% is probably an underestimate. We don't really know in primary care, but we think there's up to 330,000 unrepresented older adults in the United States. This data is a little bit old now, but that's the best that we have that I could find in the literature. So I was interested a few years ago in getting a sense of just how often unrepresented older adults are encountered in clinical practice. And so there was a survey we conducted among members of the American Geriatric Society, not just geriatricians, but other healthcare professionals as well, pharmacists and social workers, et cetera. And we found that they were encountering these folks more often than we had anticipated. So you can see that 30-40% of the time people are encountering these folks, quarterly, monthly, about 20% of the time, even weekly. So sort of a skewed sample maybe of geriatrics healthcare professionals, but encountering these folks quite often. And then what clinical concerns did they have? Well, these folks hang around the hospital a long time. If we don't know their wishes and we're using the best interest standard, maybe they're being kept, with life-sustaining treatment longer than if we had known their wishes. Quality of life concerns, unmet pain, delays in needed treatment, and then just by being hospitalized for a long time, getting deconditioned. I can tell you as having been a medical student resident, everybody knew that one patient in the hospital who keeps getting readmitted, and when they're there forever, and no one can find a place to send them. That's kind of what they're talking about here. Then the clinicians had sort of moral distress because they felt kind of like their hands were tied, that they couldn't really act in what they thought was the patient's best interest. Maybe they were worried about withdrawing sort of life-sustaining care in certain context. And then also there were some financial concerns with payers going on. And then just some qualitative comments that I think are illustrative. So here's one healthcare professional said, we couldn't find an appropriate place to transfer an adult with frontotemporal dementia who had no family or friends. No psychiatric facility would take him due to his wandering behavior and due to lack of staff for one-to-one supervision. He remained several months in the hospital. And again, that several months, that patient every day is losing muscle mass every day that they're in the hospital longer than they need to be. Another respondent said, I also think there's a gray category where somebody is essentially unbefriended. Notice they're using the older terminology here. This is back in 2019. Someone's essentially unbefriended because it's nearly impossible to get a hold of the designated decision maker. And I'll just share with you, I did practice at one point covering an assisted living facility. I remember very well a care partner who said he was only available for emergencies like on Tuesdays from like 8 to 5 or something. And of course, emergencies never happen, seems like during 8 to 5 on a Tuesday. It's usually, Saturday at 6 a.m. So sometimes someone can be functionally unrepresented or unbefriended if you can't get a hold of who their designated surrogate is. We also looked at helpful approaches to caring for unrepresented older adults, and we divided it to inpatient and outpatient. The inpatient, unrepresented patients, folks thought that ethics committees and guardians were kind of used a lot. And then for outpatient, APS, as mentioned by Dr. Lise Haggerty, and social work were the most helpful resources, according to the respondents. So, a question that as healthcare professionals we ask ourselves is, okay, so you go through a capacity assessment, and that's a whole nother lecture that I'm not going to present, but you do a capacity assessment and they lack decisional capacity. You're looking for advance directives. You're looking at the state priority order of surrogate decision makers, which will vary from state to state. And if you still can't find someone, then you're looking at guardianship proceedings. I do want to just pause a little bit and talk about the Utah Uniform Healthcare Decisions Act, again, signed into law on January 1st, because I think that is very helpful to be aware of some changes for everyone, but also underrepresented older adults. So one thing you may notice with this is that the format, like the wording, has changed a little bit. So here's the new wording of the advanced directive. And this again will be for anybody to complete. So you can see medical treatment needed to keep my body alive is sort of the intro, and you can see various different scenarios. There's also a separate question about food and liquids with kind of similar options. So patients, older adults in the community may be coming to you with these advanced directives. Um, One thing that I think is very interesting, sorry, I skipped ahead, is that there's sort of another section that's new. It has to do with priorities for care, which I think is very useful. So this has to do again with the What Matters M. And so I'm encouraging my patients to fill this out when they fill out their advanced directive, as well as any other instructions that, anything else they want people to know about that you can't capture in a checkbox. Um, there are also some optional power. These things were not in the prior advanced directive, as far as I remember. One is it talks about consent for admission to a healthcare facility for mental health treatment, and you can specify the number of days. You can also say that it can be for more than 100 days. On the right-hand side here, I think very importantly for this discussion, you can nominate a legal guardian ahead of time, and that person can be different than the agent identified as a healthcare proxy on the advanced directive form. So these are all things that show up on the newer advanced healthcare directive document in Utah. I also want to point out here for those who encounter this, particularly in assisted livings, long-term care facilities, the POLST or provider order for life-sustaining treatment. In Utah, they've chopped off the word provider. Now it's just the order for life-sustaining treatment, or OLST form. So I want people to know about that slight change in terminology. POLST is now OLST. And I think that partially reflects the fact that, not just physicians, but physician assistants, advanced practice clinicians are able to complete these forms as well. Getting back to the unrepresented, it's important again to know your default surrogate law, whichever state you reside in. So in Utah, the default surrogate starts with item 2A there. That would be someone that the older adult has identified. And then it goes down to spouse. You can see adult child, cohabitant, et cetera, et cetera. At the very bottom, you'll see someone who's exhibited special care and concern and a physician. And so I just want to point out that that is really, really important. So that special care and concern provision could cover, for example, the director of an assisted living facility who might be the only person who knows what matters to that person. The director of that facility could have some inherent conflict. They may have incentive, to bring that patient back in to their facility. But nonetheless, I think it's helpful that the law, once you through that surrogate order, you can actually turn to someone who has exhibited special care and concern for a patient. And also a physician is designated here. Notice that's in the singular, the plural. So it's not two physicians. Some states have like two physician rules. As far as I understand, Utah is a single physician who is listed in that priority order, and they're really acting at this point according to the best interest standard. And interestingly, if you go through that whole surrogate priority order, and let's say there's 4 children, and that's where you kind of land, and they're split 2-2 in terms of what to do. What happens then? Really, the Utah law is quite vague. You can see at the bottom, if the class, meaning like the priority order of surrogates, where you land there, remains evenly divided, a healthcare decision must be made as provided by other law of the state regarding the treatment of an individual who's found to lack capacity. So I actually asked one of the University of Utah legal folks about this, one of the attorneys, and they just said this is quite vague. There's no clear guidance on what to do. So you're probably again looking at going before a legal proceeding at that point. Once you're sort of in the land of guardianship, if there's no available surrogates, that's when things get very sticky. And that's why I think it's really important, again, to be proactive and try to prevent this situation if you can. But for some patients, there are advantages to guardianship that are really important. So someone who has severe dementia, going to be living in a nursing home for the rest of their lives, having a guardian is absolutely appropriate if there's nobody else. Some of the cons are that if you have guardianship assigned for medical affairs, or for anything for that matter, it can be very difficult to remove guardianship once it's assigned. So someone who's in the hospital is not really in a position to go to a court hearing. Also, if you have an agency providing guardians, they may not be known to the patient and may not be aware of what's mattered to them over time. So you may have some mismatch again between their wishes and what actually happens in terms of decisions. And those can be called stranger guardians. Um, I wanted just to present for reference the American Geriatric Society position statement on the care of this population. I was privileged to be involved with this group. This came out in 2024 as a revision to the 2017 statement. And I won't go into detail on all the recommendations, but they're basically divided into clinical and policy. And perhaps the two most important updates were that we are changing the terminology. And that might seem like a really minor thing, but it's actually really important because, as one of my colleagues says, if you can't name a group, you can't claim it. In other words, come to agreement on terminology. So unrepresented, while not a perfect term, kind of does a better job at capturing this population because it's actually possible to have friends yet still be unrepresented. So if those friends are not available, then it doesn't really help in terms of having a backup decision maker. And I also mentioned previously that really the importance of working proactively to prevent those patients who still retain decisional capacity to prevent them from becoming unrepresented. And you can see here they talk about legal standards, state laws, and protections and procedural fairness. All those things remain important. So a few opportunities to be proactive. And again, this is my bias from the healthcare perspective, but I often have patients coming in to see me who have Medicare annual wellness visits. That's a free visit offered by Medicare that talks about preventive health. That's a great time to talk about advanced care planning because that's part of the Medicare AWV visit. There is a separate advanced care planning code, so healthcare professionals can get reimbursed for having advanced care planning discussions, not just in the office, but also in long-term care facilities and assisted living facilities. You can use those codes. And whenever, as a clinician, you see that there is concern for social isolation, someone recently got divorced, widowed, they're estranged or geographically separated from family. I actually had a heartbreaking case where a patient had moved to Utah to be closer to family, and then the family decided to move away, and the patient was kind of stuck here on their own. Like I think that happens more often than we think. Um, and then on the inpatient side, where we often see older adults who are unrepresented come in, they've been lost to primary care follow-up, and they just show up in the ER. The new CMS age-friendly hospital measure that I talked about earlier presents some opportunities to be proactive, and I'll talk about those. So if you remember, there were those age-friendly domains that all hospitals have to attend to. If you take two of those domains, domain one talks about eliciting healthcare goals and things like living wills, identification of proxies, and advanced care planning. Currently, most hospitals are simply asking yes or no, do you have an advance directive? But this kind of takes it to the next step. And then under social vulnerability, screening them for specific issues, including social isolation. And then it goes on to talk about things like elder abuse. Those kinds of things are probably going to identify patients who you can intervene upon at the time of hospital discharge and get them connected into community services like 211 and others to get them the care that they need. The AGS position statement also goes through multiple recommendations in clinical practice. And this first one is really important. It basically says that if you kind of wing it and don't do a structured capacity assessment and have structured approach to medical decision making, you're just going to sort of end up with a decision and a recommendation that may not reflect the patient's goals. So it's important to be systematic, and item 2 talks about that as well. And 3, in fact, just a structured methodology. That becomes really important when it's a urgent situation, you don't have time to call a backup decision maker. then the attending physicians really have to use retrospective review to make sure that there's oversight of their decisions. We talked a little bit about number four, having access to a surrogate familiar with someone's situation, particularly patients in nursing homes. And number five, you often have ethics committees involved, and those groups really need to take a broad look at this and look at the medical record, talk to key informants to make sure that we're not embedding individual biases. And that's, I think, one of the things that makes the single physician thing hard because that physician is going to carry sometimes some biases. So having more than one person involved is usually a good thing. Just the last couple slides. In terms of what to do once someone becomes unrepresented, it really is murky, and I think it does depend on the individual situation. I think many of the resources that Dr. Elise Haggerty mentioned would come into play. I want to mention this called WINGS, or Working Interdisciplinary Group of Guardianship Stakeholders. And it's really a partnership with the legal system so that that legal system is constantly improving the process in terms of guardianship and conservators, folks from all different sectors. Some states have sort of volunteer programs where they sort of galvanize pro bono legal services for patients in this situation. So just to say that groups like this can be helpful, but I don't want to say this is easy. Once someone goes from an older adult without a surrogate to unrepresented, it gets very, very challenging. And I do, as a clinician, often feel out of my depth and need to rely on my colleagues for help. So back to the age-friendly ecosystem. Again, I think not just about the healthcare system, it's about the context in which we find older adults and drawing upon all those resources. So to summarize, unrepresented and older adult without potential surrogate are preferred terminology that increasingly are replacing unbefriended and adult orphan, especially in the literature, but also I think in clinical practice. In a sense, an unrepresented patient can't really represent themselves. That's kind of the core of the definition. Geriatrics healthcare professionals frequently encounter these patient populations, and it often causes moral distress, which is a real harm. Also could affect things like burnout for healthcare professionals, which is a real issue. And just to kind of conclude that the age-friendly health systems, the focus on what matters, I think if you look at the care of these folks through that lens, it does provide opportunities to proactively identify those folks at risk of becoming unrepresented. At this point, I'll go ahead and turn it back over to Rob and Tracy.
Thank you, Dr. Farrell, for your time and for your incredible presentation. A lot of wonderful information there. Tracy, I'm going to turn it over to you to kind of headline the Q&A and make you the host for that. Do we want Megan to assist with that? Keeping an eye on that if I have to step away.
Sure. As of right now, there are no questions in the chat. So, audience, this is your chance to ask questions of Dr. Haggerty. Excuse me. And Dr. Farrell.
While you're thinking of your question, I just want to reflect back on what Tim was talking about with the updates in the system related to the documents in the state. The advanced directive did have those changes adopted and was worked over fairly thoroughly by interested constituent stakeholders, including the legal team at the University of Utah Health Systems and a group the commission put together. And the most current document is dated June 1st and is sitting in the Utah Commission on Aging website, utahaging.org. We have shared back with the Division of Aging and Adult, with the Department of Health and Human Services, the adjustments. It still honors everything in the code, but also made it a little more user-friendly. The OLST agreement that Tim referred to is under review in terms of trying to make it more user-friendly. We have a team working on that over the next month or so, and we'll work with the state in order to make that document a little bit more user-friendly. It's a really critical document, and at this point, it's just kind of in a state of, it can be a little confusing to navigate. And so we want to make sure that that is as user-friendly as possible while still maintaining how critical the information is to capture. So apologize for that little insert, but I want to just make sure folks were clear on the progress on that.
No problem. Okay, we got a couple questions here, and then I know another one that came through email. The first one is, how do you suggest that people manage the risk of independence versus financial protections? And that could be Dr. Farrell or Dr. Elise Haggerty.
Maybe I'll just lead off and just with some thoughts. One is, I always think about capacity first, that if patients have the capacity to make financial decisions, there's a range of decisions for which one can have capacity or lack capacity. But assuming they do, thinking back to the example of Jane that I talked about earlier on, I think one of the things that her sister is doing is giving her, leeway within with some guardrails attached to it. In this case, Jane, even though she's not forthright about the romance with Jason Momoa, she has been willing to work with her sister and feels quite comfortable with, having maybe a debit card with a certain amount in it so that, she can spend money maybe in ways we don't like, but there's always that balance because we don't always have to like what patients or older adults do. Even so, if they retain the capacity that, they can make bad decisions. But I think maybe just putting some more guardrails around that. I would also add that I think, Rob, it was called the Bank Safe Initiative once upon a time. I'm not sure if that's still going on, but I think financial institutions have a role to play in sort of flagging risk factors. But I'd say, again, it comes back to capacity and, sometimes being okay with making bad decisions, just trying to make them a little bit less catastrophic when those bad decisions are made.
And that program still is in play, and AERP has got a lot of information related to the banking safe, and there are expectations for the financial institutions to play a role. Tracy could actually say much more about that.
Okay, thank you. Next question. Is there any sort of quick reference card to help ER nurses navigate through identifying potential cases of abuse? And Kristen there.
Yeah, so glad you asked. We actually, at the National Collaboratory to Address Elder Mistreatment, designed, tested, and now disseminate a toolkit for helping emergency departments screen for and respond to elder mistreatment. And that includes, sites can adapt it to their needs, but it typically includes a very brief kind of pre-screen that can be asked typically at triage or early in bedside, and then an algorithmic tool to help you decide, do we need to do a more extensive screening, and then how should I respond to this case? I'll put a link in the chat to those materials for you to see, and then also my email, because I'm happy to talk more about it if it's something that you think you or your site would like to consider implementing. It is one of the implementation toolkits that's available through the Geriatric Emergency Department Collaborative as one of the quality improvement initiatives that you can use to achieve or level up in a geriatric emergency department accreditation, which is a nice sort of carrot to help folks get traction if they're interested in implementing. But I'll put it in the chat, and if you're interested, happy to chat more one-to-one about how it can be done.
Thank you. All right, the next one. There are strong efforts right now to get advanced directives and the OLST into the hands of older adults. Are there any weaknesses in the system that should be addressed?
I can take that one. I'm thinking back to an effort a few years ago to get the first responders an electronic pulse. I think that was a pilot program, Rob. I don't know that that was sustained, but I feel like that's a really innovative approach, because if that document is sitting, in someone's filing cabinet or in their safe deposit box, and it's not available to folks, that's not going to be useful. So I would say one of the things is, across settings of care, having ready access to that document is hugely important. I think we're making some strides with that, particularly with electronic health records that are increasingly interoperable across health systems. But part of this also is just simply getting more people to complete these documents. It's part of the Medicare annual wellness visit, but there are lots of other opportunities to do this. So whenever somebody is discharged from the hospital, these documents should be reviewed, for example, because their goals may have changed. There's a clinical situation that may have changed substantially. I don't know, Rob, do you have anything you want to add to that?
Yeah, I really appreciate the bringing it up, Jim. The pilot existed. There are some people on this call that were part of that, and it has revived, and in large part because we now have a major group that has come together and has made this one of their priorities. The One Utah Health Collaborative Utah. Alan Ormsby is on this call. Alan, I'm going to ask you to take a moment and just share kind of what you're seeing as you and I both work on that group, but to get your voice on the table here. Would you mind just comment a little bit about the progress we're making on that? Maybe we lost Alan. Anyway, all I will say is that it's alive and well, and we are moving forward with some new partners to make a mutual repository that is accessible to EMTs, all providers, individual input for both advanced directives as well as OLST agreements in the state.
Thank
It's
you.
not
Alan,
get it when you need it, right? Yeah.
Alan
Thank-
was on. He dropped off. I wonder if he's going to drop back on. I saw he was on when you said that. He might have been having trouble with the sound. Okay, the next question. What is the benefit of the PULST agreement versus an advanced healthcare directive?
Yeah, I'm happy to take that one. So I see the pulse, again, it's a physician order, right? So it's a different type of document. It's not technically an advanced directive. It's a physician order, but it should be very much aligned with an advanced directive, and it's very actionable. So it has very specific fields like, if, my heart should stop and, that kind of thing. Do I want sort of aggressive care or sort of limited sort of care, comfort care? Do I want feeding tubes? Do I want those kinds of things? So it's just much more specific, and I think it's helpful, like at 4 a.m. when there's a crisis, and let's say the nursing home staff needs to know, do we ship this patient to the ER or not? Whereas an advanced directive, it will, maybe provide some more general guidance, but from a medical perspective, it's just a little bit less specific. And so I think for particularly long-term care staff, that OLST form is a little bit more helpful in those crisis situations.
Tracy, I hate to jump in here, but this is our arena, and I want to just back up what Tim said. An advanced directive applies to any adult over the age of 18. And this is where you're basically designating an individual to speak in your behalf if you cannot. And the OLST agreement does address issues with more detail on palliative care, recognizes the agent, nutrition, all of those things that Dr. Farrell pointed out. Oftentimes, when someone's either near the end of life or expected to be near the end of life. But so they have different purposes. One has to be signed by a provider, a medical provider. Another one has to just simply be witnessed by a non-interested party. They both have a role, but they are different, with the advanced directive primarily being to name an agent who can speak in your behalf. Those current documents and the explanation between the two types of documents can be found at utahaging.org under the advanced care planning section.
Great. Thank you, Rob. Okay, what can providers of services like Meals on Wheels programs do after someone has been identified as being at risk of becoming unrepresented?
Kristen, do you want to take this one, or do you want me to start off?
You can start off. Thanks.
So, so I think this would be a great time for, someone in the community recognizes that there's an issue here. I think maybe asking the question, just maybe probing a little more about what their support system is like, and when was the last time they saw a primary care physician? Do they have any of their wishes documented anywhere? I know sometimes their wishes are only documented like in the notes, like the clinical notes, and not in an advanced directive, but maybe trying to get a sense of when's the last time they interacted with, whether it's a healthcare system or other social services, to what extent are they connected or not? And then trying to find maybe some thread there that would sort of tie them back into either primary care or other services. But I don't know, Kristen, if you have any thoughts about that?
I think that's right. And I'm, I hope that Tracy would agree. I think when there's question about what to do next, if you're concerned, you can call Adult Protective Services and ask for resources. So if it's a Meals on Wheels person and they're just not quite sure what to do next, go ahead and call APS and to explain the situation, tell them you might be concerned that there's risk, either for, you know, unrepresented older adult or specifically for elder mistreatment. Would you agree, Tracy?
I think Adult Protective Services, definitely if you're suspecting that they're at risk of abusing themselves, or well, typically in those cases, it's self-neglect, call Adult Protective Services, report it. Also contact your local area agency on aging, see if they could get connected to some services. I think one of the questions that did come through an email that would be a really good follow-up is something that comes through Adult Protective Services a lot is we talk about capacity as people either having it or they don't. But we come across a lot of those individuals who are just in that limited range, where they are not making the healthiest and safest choices, but they're not ready to have a court order and be removed from their home, but they're also not willing to engage or connect in services. Do you have any recommendations on how we can work with people on trying to get them engaged in their own care and recognize their environment and that they're not making the safest choices while also respecting their rights and their wishes? Any ideas on that?
I'll just say that again, back to the what matters. Not this is going to work in every case, but I find that if I were as a physician to go and start rattling off various services, I'll probably do that eventually, but I think that's less effective than asking an older adult, what brings them joy every day? What does a good day look like for them? Um, what's most important in their lives. These are the underlying principles of like patient priorities care, and what matters is you start with the values. Then from those values, which tend to be stable over time, you reach goals, and then you can align services and or medical care with those goals that are based on values. So I would kind of start there, and that's very differently than I was trained, right? It's really easy for me to throw a bunch of options at someone, but if it's informed by what their values are and their goals, I think they may be more likely to want to engage.
I like that.
Yeah, and I was going to sort of similar talk about, one of the evidence-based programs that I was describing, the RISE model, is around meeting the older adult where they are and what they want. And sometimes that's different than what we think is best or right, or what the family members, if they're not unrepresented, what the family members or friends think is best or right. And so being careful to do that and using small goals, goal attainment scaling type interventions can be really helpful.
Great, thank you. Should one update their living will to currently aligned with updates to OLST?
That's a great question. So there is a box on the, I guess, former Pulse form, now ULS, that says, the doc or whomever is signing says this document, the advance directive has been reviewed and the documents align. So I think the big picture answer is yes. I would just say that the living will tends to be more of an legalese and much, much less into the specific healthcare interventions. What I find is probably the most common, anecdotally common misalignment is what happens is someone has a living will that they had done maybe as part of their estate planning like a decade ago. And then the folks that are named as the surrogate decision makers have passed away or are no longer available. And so I will often encourage patients to update the living wills, just to make sure there's alignment in terms of who is named on the form. Oftentimes the wishes are the same, but the people have changed over time.
Thank you. Okay, Dr. Elise Haggerty, I think this one is in a follow-up to the emergency toolkit. Is there a similar identification tool for first responders?
Okay, I'm going to hit send on my chat. There are several tools that will be useful for first responders. The first one that I put in the chat is just an online e-learning course offered that we developed actually on the National Collaboratory for EMS providers. It's not a screening tool, but it does talk about identifying and identifying observational red flags, how to talk to people in their homes about the risk for elder mistreatment and what you're seeing, and then respond to. So it's an e-learning course through the NAEMT, and it can be used for recertification for EMS. The second was developed by the National Center on Elder Abuse out of USC. That's a training for law enforcement called EAGLE. And that has some really helpful resources as well. Actually, there's resources in there that are helpful for a lot of folks and community organizations and such, that not just law enforcement. And then specifically around the question for a screening tool, there is the DETECT tool, which was designed, it's entirely observational, and it was designed for emergency medical service providers. It's been validated. So that's a link to an article on it. And that tool is now actually being adapted for use in home-based primary care. So those are a few different resources that may be helpful for first responders.
Thank you. All right. Can it be considered elder abuse if a person who cannot care for themselves has family members who could provide care but refuse to do so?
I might punt that one to either Kristen or any legal professionals, but I guess my first thought is perhaps if someone has if someone is able to provide that care but refuses to do so, but I hesitate to comment because it sounds like this might be getting into legal issues. I don't know, Kristen, if you've encountered this.
I don't know. Is a great question. I guess I would assume the opposite, but there is a growing body of research around what it means to be a caregiver and who want to be called a caregiver. So I'm not super familiar with it. I don't know, Tracy, if there's a definition of.
I chuckled at that question because I'm like, it's going to get punted back to me. And the answer is it's not black and white because it's depend. A lot more questions have to be answered. Are they living in the same home and they're not providing care? Are they living off of their resources and they're not providing care? Is it a family member that, maybe lives out of the state or out of the country and they haven't had any relationship for 10 years and the person lives here? And they're on their own and they're not caring for their parents. I mean, there's so many dynamics and this is where if you suspected that, I would recommend calling our intake team, making a report, because they're going to ask those additional follow-up questions to see if it does fall under financial exploitation, does it fall under self-neglect or caretaker neglect? Because there's just a lot of follow-up questions that would need to be asked to answer that properly. But I agree, maybe.
Yeah, it's a great question, a thought-provoking question around elder mistreatment prevention, because if somebody is not providing that care, why are they not willing to provide that care? And can we provide some sort of intervention for the caregiver to say, okay, not every family member can provide every type of care. And you may not be the best equipped to provide kind of physical care for an older adult with dementia. You're not going to bathe your mom and dad with dementia. It's very difficult, but you might be well equipped to do another aspect of caregiving. So trying to figure out the what and the why to help a caregiver or a potential caregiver fill in gaps where they can without completely overwhelming them and increasing the risk for elder mistreatment. I like that question. That was good.
Yeah, it's a good one. All right, we got him coming in here. Let's see. Okay, Rob just had to step away. He's presenting at the Home Health and Hospice Conference, where I will be in a couple hours. Okay, we have some providers who are not using the incident reporting to Office of Licensing. So that's something that is specifically here in Utah because they do not want to get in trouble when their staff abuse or neglect their clients. How do you recommend that the staff navigate promoting incident reporting while ensuring consequences for unlawful activities by staff caring for aged adults?
How do you recommend that the state navigate?
How can we encourage incident reporting? It sounds like in facility care, correct me if I'm wrong, Andre who put the question in there, to report because they're not reporting abuse and neglect of their clients.
I don't know. It's tricky. And I hear this too with EMS not wanting to report what they see in a home because that might affect their contract with the nursing home agency. That's a tough one. I don't know. Tim, Tracy, do you have thoughts?
I would just say that thinking about I practice at the University of Utah, also the VA, there's always these required modules we have to complete about this type of reporting. And I think part of it is cultural. And these are, you know, there may be myths about what happens if you report, and some of it's education. So I think I'd say culture and education would be the places I would start. But that's a much there's more to the more layers to this onion for sure.
Yeah, I definitely think more education is something that's been really cleared up about, and understanding, especially for those that work in facilities, the penalties that occur if they don't report, that are often stronger than if they do report. And so just making sure that they do report, making sure they understand when and why to report. And that's where we actually are working on getting an e-learning portal up and developed so that anybody in the state of Utah can go and take a training on adult protective services, when to report, when to look those signs to look for. And so we are hoping that that is going to be up here in the next 2 or 3 months. We're just getting in the final phases of it and then need approvals. And so education, I think, is key there. And oversight, and just not being afraid to tell people that, hey, we're a mandatory reporting state. And by law, you do need to report. Rob just put in the chat that this program will be uploaded to the Utah Commission on Aging website within a week. So you will be able to watch the recording here. And then Dr. Lise Haggerty has put several resources in the chat. Alan has said, keep in mind that a living will is an outdated term. It should be called advanced directives. And then there's another question here. As a forensic nurse, we are sometimes called for sexual assault or domestic violence cases for older adults. Is there something specific for our team? So that's probably back to the tool for you, Dr. Haggerty.
Yeah, so we don't include in our training like specific modules for people with forensic nursing training. What we tried to do is borrow from some of the forensic nursing approaches in developing our training, but that group of nurses are particularly well positioned to train as a clinical champion for implementing an elder mistreatment screening and response protocol. So it's sort of a non-answer because I don't have additional training for you, but really encourage folks with the forensic nursing background to lean into the issue and participate in some of the more general trainings, because I think your background and interest will be especially useful in those cases.
Okay, and then Alan Ormsby, he is the director of AARP and a partner on this planning committee. He said spouses do have an obligation to care. Alan, do you want to, if your sound is working, do you want to pipe in and add anything to that? Alan's also an attorney. Probably doesn't want me saying that. It looks like Alan's having trouble with his sound.
Yeah, Alan's not, we can hear him from his office, but we can't hear him on the webinar.
Oh,
Darren, take your computer by him. That's all right. Okay. Well, this is great. Are there any other questions? This is, it's been a great series. I want to give, just before I wrap it up, I want to give anybody else a last question. All right. Well, we want to thank everybody for attending our 6th annual Utah Elder Abuse Awareness Day event. We held it one day late just because yesterday was a state holiday. We want to thank our speakers, in particular, Nels Holmgren for talking about the WISE initiative, and then big shout out to Dr. Lise Haggerty and Dr. Farrell for their expertise in the field. I've never met 2 people that just have such a compassion and caring. They're researchers in the field. They do this and give of their own time to do this. They've worked with Utah on many projects outside of just this conference, and they are great leaders in the field, very approachable, and they might not like me for this, but I'll be like, go to them, contact them. They're great, and we appreciate all of their conversations. All those participants will be emailed PDFs of the presentations by Rob if you registered as yourself and came on the call, because Rob is the host of the Zoom link, and he will send those out. And then, like we said, the recording will be available on the Utah Commission on Aging's website in a week's time. Thank you, everybody, and have a great day. And let's all work together to keep our community safe.
thank you so much.
Take care. Thank you.